realize.
Good evening. Welcome to iFocus lecture 56. Today we have Dr. Himanshu Matalia from Narayana, Nethralaya, Bangalore, speaking to us on a very important topic of dry eye diseases, diagnosis and management, which is important not just from the perspective of the examination, but also in future practice, because it's something that is becoming very common. To introduce Himanshu, it's a pleasure. He completed his medical education from Jamnagar. Then he was a fellow at LVPI. That was a very pleasant time we all spent together. Himanshu and his wife Jyoti, they were all fellows together. And he probably was the first clinician scientist. When the term did not exist in India, he was very keen on research. So he joined Dr. Sangwan and Geeta Vimuganti and practically set up the stem cell lab at LVPI informally. Otherwise, it was working anyway. And he got involved in research very deeply. And finally, he went to Narayana Nethralaya to head the cornea service at NN2. And currently, he is the medical superintendent of NN2. So that is the head of NN2, I suppose. So that's great. So Himanshu has risen professionally and personally, and he's a great speaker. So it's a pleasure to have him speak to you on dry eye diseases. Thank you, Himanshu, for your time, and I welcome you to share your screen.
Thank you, Dr. Santosh, and I must thank, and at this juncture, I must say that Dr. Santosh is one mentor which I wish everybody should have, and he's a kind of person who can help you to rise professionally and personally at every level. And I'm so fortunate to have him as a guide and mentor for such a long time. And whenever he says something, all I have to say is yes. And so this time was also no different. Thank you, Dr. Santosh, and thank you, Team iFocus. So I'm here today with my presentation on evaluation and management of dry eye. What's new? But most of the time, we do read about such things in our books and all those things. So I'm not going to go on those routine path. I'm not going to go to teach you any theory, but it's going to be more practical, and it's going to be more something which is relevant now. So when we talk about dry eye, the question arises, why do we talk about dry eye? I mean, why is it important? The dry eye, mind you, is a big burden on the society, not only internationally, but in India, if you look at the numbers, the prevalence is as high as 40%, which is huge. That means every other patient walking into your clinic might have dry eye, and you must know the subject. If you look at the economical burden, though we do not have data from our country, but from US, that's something staggering, almost $3.8 billion, which is huge amount. And that's the reason why even industry is very keen on that. Every other company which comes out would first start with a dry eye kitty, and that's why dry eye is important. The dry eye classification were many, and it evolved in last few years to a little more standardized classification. And as the dry eye disease classification goes by Deuce 2 final, the last classification, which was by Deuce 2, which classifies dry eye into asymptomatic, into symptomatic, which has signs, which does not have any sign, and finally to classify them into something like aqueous deficient dry eye, evaporative dry eye, or mixed variety. So whether it's the Deuce 2 or whether it's Parallel Society, which is Asia Cornea Society, mainly centered around Japan, and where the dry eye work is done primarily in pure research level and very nice niche level. Even the classification there involves aqueous deficient dry eye, decrease wettability, and increase evaporation. So basically it turns out to be that we are classifying dry eye into either aqueous deficient or evaporative, and either mixed variety of dry eye. The treatment-wise, according to the Deuce 2 approach, after doing a triaging question and looking at the risk factor, the diagnostic tool includes, very importantly, questionnaires And then diagnostic tests like non-invasive or invasive tear film breakup time, osmolarity, and ocular surface staining. So if you look at all these things, it does not require a huge amount of armamentarium, or you does not require a huge amount of setup to do a dry eye diagnostic. But if we look at the sequence of them, but there are sequence which involves first those non-invasive tests, or those tests which are very sensitive to touch and those things. They need to be done first, like MMP9 level, non-invasive tear film breakup time, lipid layer analysis, tear film height, abrometry, and all such kind of thing. However, these are not mandatory. The mandatory test which we normally must do includes fluorescent breakup time, the staining of ocular surface using Lissaman green or rose bengal, Shermust, and the meibography also. So these are the mandatory tests which we must know about. Nowadays, with all these mobile practices where consultants are visiting consultant, well, you can actually make all these things concise into a small kit, and you can be a visiting dry eye consultant who can hip, skip, jump, and go to different practices. So it's not very difficult to have the diagnostic devices or things which you need around you in a compact way. Coming to the questionnaire, the first thing what we have to understand is the questionnaire part. Now, there are many questionnaire, whether it's McMoney's questionnaire or currently favorite OSDI questionnaire, what we use here. I do not have any financial disclosure here, but this questionnaire is commonly used across our country. So OSDI is something which we normally use. Along with that, there are some questionnaires like speed questionnaire. They also, the question arises, why do we use questionnaire? The answer is, well, the disease also has some subjective part of it, where you need to subjectively document how much the problem or severity of the problem is. So whenever you treat them, whenever in the classification we saw that there are cases where they have significant symptom without having much signs, and there are cases they may not have much symptom, can have signs. So if you only look at the signs and only look at the test involved, you will miss out on large number of patients who actually can be more symptomatic without having any significant damage on the surface. So that's why questionnaires are very, very important. And it also tells you how much it affects the quality of the life. Coming to the test, the common test which we do are fluorescent staining time. Please remember, when you use fluorescent staining, preferably use something which is water-based, and do not use a lubricant drop, which can be more viscous because it may not dilute the fluorescent staining. Also, try to avoid using any surface toxic medications like paracaine or any lignocaine kind of formulations. Preferably, I use a non-preservative antibiotic like moxifloxacin, and remove the excess stain on a tissue paper, and then touch a just gentle drop on the lower palpebral conjunctiva, and that's the only amount of staining which you need. After that, you can see the patient on a filter which is called rattan blue filter or rattan yellow filter, I'm sorry. And the rattan filter actually filters out the excess light, and it can give you as beautiful image as you can see from here. So the fluorescent staining, the tear film breakup time, the rose bengal staining. The rose bengal is a dye which does not dilute very easily. So what you can do is take a drop of your diluent and take 2 strips of rose bengal and rub them with each other, create some drop, which is hanging drop, and then touch on the surface of the eye. However, a Lissaman green is much more friendly on the surface, and which is preferred stain. The Shermust test, as you routinely do in most of these cases, has been very, very well standardized. But remember, not to touch the strip on the tip, because your oil from your hand also can get impregnated into the strip, and which may not become as wet, though it's more theoretical than practical, but you certainly do not want to touch the tip of these things. These tests are very well documented. The important part of the documentation is surface staining documentation. Again, there are many different ways of document ocular surface staining. The corneal, what I like is, I like to document the corneal staining and horizontal demarcation, so superior, middle, and inferior, because many times the cases which leads to ocular surface staining also leads to distribution in these zones. So that's why practically it gives me sort of a clincher of a diagnosis which I'm dealing with. So I would prefer to divide the corneal staining into like superior, middle, and inferior part of the cornea. Whereas the ocular surface staining across the entire ocular surface can have, again, many systems, but what I prefer is American Society of Rheumatology, which they have given the point system, and which again helps you in following up your case, whether it's improving or not improving, all those kind of things. Another interesting thing which was again given by the Asia Cornea Society was the pattern of tear film breakup. Now, tear film breakup time, we all know that it should be a random spot, and that's what we are taught. But what was not told about was the pattern of break. Now, that's what these guys came out with, and they found out that, you know what, the pattern of break itself can give you some idea about the diagnosis, like a line break, or if you have an area break, which can be related to aqueous deficient dry eye. If it's just a spot break, which can be related to evaporative dry eye, and if it's something like a dimple break, which is related to the decreased wettability. So even the break pattern can actually give you some idea about the etiology. But looking at all these things, coming back to the diagnostic test, the common diagnostic test or gold standard what we are taught is symptom questionnaires, the quality of vision, ocular surface staining, tear film breakup time, and Sharma's test. But if you look at all these things, do you think any of these things can tell you about the diagnosis? Is it the root cause which you can find out from these tests? Of course not. We are not talking about the root cause. We are talking about effect. Whatever that root cause has done on the surface, we are talking about the effect. So, I mean, does it matter? Can we just put the drop and that's okay? Why do we worry about that? In fact, the problem is that not all the dry eyes are same. Do you think the dry eye, which is in a patient of a rheumatoid arthritis, can be same as somebody who has MGD just because Shermer values were same? Well, of course not. We all know that they're not same. And if they're not same, then shouldn't we treat the root cause and rather than treating the effect only? The answer would be yes, of course, we should treat the root cause. And that's where we should study the pathogenesis of the disease. So when we talk about dry eye pathogenesis, the major part of the dry eye pathogenesis can be incorporated in this cartoon. One of them, very important part, is hyperosmolarity. Now, hyperosmolarity is a known factor which has been studied widely and reported widely that increased osmolarity can lead to surface damage and can lead to dry eye, and it's a vicious cycle. The instrument which can measure this thing is called osmometry, and currently we have one from the Tear Lab which can measure this thing. The cutoff value which is given is 360 milliosmolar per liter. More than that, we call dry eye. Less than that, we call borderline. If less than 290, they're called normal. But the interesting part about this thing is when you dwell into this subject a little more, you find that there's significant crossover between normal values and dry eye values. So that means even a normal person can have abnormal osmometry, and a dry eye patient can have normal osmometry. Well, that's dangerous, right? And also, more the drier the eye, more is the variability of the reading. So a normal person can have quite nice repeatable reading, but a dry patient may not have very repeatable reading. So with high abnormal variability and being very expensive, it's not on top of my list when I have to do this test or when I have to buy this instrument. If you look at the literature, even in the literature shows that severe to mild disease, the osmolarity values may be same. Not only that, even the etiology wise, Sjogren's, non-Sjogren's, even normal cases, osmolarity may be same. So I don't think it helps us in diagnosis also. Treatment wise, now coming to the treatment of hyperosmolarity. Well, what if we know that surface is hyperosmolar? We can put hypoosmolar drops on the surface. Interesting part, it doesn't work, because within 1 or 2 minutes, the osmolarity would come back to its pre-existing level, and it's useless. So using using hypoosmolar solution also is not a treatment for hyperosmolarity. So no, even treatment-wise, it does not help you. So how do we treat that? Well, the treatment lies that whenever you have hyperosmolarity, you can have certain solutes which can go inside the cell and prevent the swelling of the cell. Now, these are small solutes which can go easily inside the cell. But again, depending upon their molecular weight as well as the molecule, some of the molecules like glycerol can go rapidly inside, can maintain the osmolarity so that it can prevent the damage of hypoosmolar solution, a hyperosmolar solution, but it can leak out also very fast. Some solutions like erythritol, which can go very easily inside the cell, but leaks out a little slowly. So it can give you osmotic protection a little longer. And things like L-carnitine, which requires an active transport to go inside as well as come out. It goes slowly and also goes probably okay, but comes out relatively slowly. So it gives you all these combination can help your cell to survive an osmotic damage. So though you may not be able to detect the osmolarity accurately, though you may not be able to treat it accurately, well, you can survive. So your lubricant, when it has osmoprotecting agents, well, it can help you. So we wish that all our drops, lubricant drop, should have osmoprotecting agent. Coming to the next part, which is inflammation. Now, the inflammation and the dry eye earlier was not known. Till Dr. Fluckfelder's group from United States, they came out with their studies and showed us that though the eye looks quiet, but there is significant amount of inflammation there on the surface in these cases. These inflammations can be called white inflammation because you don't see the congestion always. It's also related to the neurogenic inflammation, increased osmolarity, and all these kind of thing. And even the systemic diseases also can lead to inflammation. It's usually mediated by T cells, interleukin-17 and MMP9. And Fluckfelder's group studied the level of MMP9 and they found that we can actually detect the MMP9 using certain simple tests in our clinic, like how we do pregnancy test, and it actually can give you a pretty rapid result outcome. So how does that help? Well, the MMP9 level, when we check using these kind of inflammatory devices, it tells us, it's a qualitative test, so it tells us, is MMP9 level more than 40 nanogram per ml? Now, according to studies done by Dr. Fluckfelder's group, they found that normal people did not have more than 40 nanogram per ml level, but the dry eyes had this level. So to be on the safer side, when it's more than 40 nanogram, we can assume there is significant inflammation there. So if we find there is significant inflammation, well, we can treat it. And if we find this ocular surface does not have any significant inflammation, we may not need anti-inflammatory molecules to treat that. So look at this thing. If you have higher level of inflammatory markers on the surface, well, you can start them on anti-inflammatory molecules like cyclosporine, tacrolimus. We have cyclosporin available in our market as 0.05% or 0.1%. Earlier, we used to reconstitute it in 1% or 2% formulation also. And the tacrolimus is available for dry eye, as well as I would say not available for the dry eye purpose, but it's a off-label use which we do, and it's 1,000 times more potent than the cyclosporin, so if patient can tolerate. And those patients who have significant amount of inflammation, like severe Sjogren syndrome, somebody with rheumatoid arthritis or any other connective tissue or collagen vascular disorder, neurotrophic keratitis, well, these guys can definitely be of help to these kind of patients. So anti-inflammatory molecules must be combined with lubricant drop. Initially, you can combine them with topical steroid also. These molecules are very mild, so do not expect a miracle within no time. So you have to wait for a little longer time, maybe 4 to 6 months, according to whatever the industry tells us. But at least a couple of months is something which I would certainly give it a time. We must have realistic expectation, as well as the patient should have realistic expectation from these things. So inflammation and dry eye can certainly be of help if we find out how to detect that. Then comes another thing, which is tear film instability, and which is most commonly seen in meibomian gland dysfunction, and very commonly now we diagnose it. Earlier it was underdiagnosed, and now I feel it's overdiagnosed. The meibomian gland dysfunction typically occurs with either blepharitis or MGD. These things can lead to poor tear film breakup time, and your BUT can be abnormal. Earlier, we were taught that whenever we see lid margins have blocked meibomian glands, or you have inflamed lid margin, and the TBUT is abnormal, well, all you have to tell them is warm compressive lid massage, and that's going to be the treatment. Well, the interesting part came later on now, and we got one investigating device called meibography. Now, meibography is imaging of meibomian glands, which we know are vertically oriented. In upper lid, more of them; lower lid, less in the numbers. Now, these glands, if you can see here down, this is one of the image of meibography in the upper lid and abnormal image in the upper lid on your right side. You can see on the right side significant loss of meibomian glands, whereas on the left side, the meibomian glands are present. So why do we need meibography? The answer lies that according to a conventional teaching, MGD, well, we tell them to do warm compressive lid massage. But when we do meibography, and if we find out that the meibomian glands are present, well, it may work. But what if the meibomian glands were absent, like as you can see in this case? Well, whatever you keep on doing on the lid, nothing's going to come out, and the treatment would be useless, right? So think about it. A simple thing like a meibography can help you decide about the treatment of your MGD. And that's the reason why meibography is an essential tool in your dry eye diagnosis. So apart from all your Schirmer's, PUT, apart from the staining, I would consider meibography as very important tool. Now the question arises that everybody may not have meibographer. But I didn't have meibographer long back because there was no meibography there. But I realized when I was playing with my autorefractometer that when I flipped the lid of the patient, I could actually see all the meibomian glands. And that's how I discovered my meibography earlier, long back before meibographers were available. And I started doing meibography in all my patients. So you do not need meibographer, or you do not need even autoref. any device which has infrared, most of the time may be able to image your meibomian glands. And people have even reported your infrared camera, your security camera, to be used as meibographer. So, of course, meibographer are there, which are very good, and there are many diagnostic devices which can actually help you to diagnose dry eye completely. One of such devices is Keratograph IM and Ocular Surface Analyzer. I do not have financial disclosure here, but it can help you. These kind of devices can help you to look at meibography, to look at non-invasive TFM breakup time, lipid layer, your many scores on the surface, as well as some of them can help you with the topography, as well as even capturing the images. There are certain meibographers, standalone meibographers also available in the market, which can also analyze the loss of meibomian glands in percentage and score it also. There are some other devices like LipiView, which is using a laser interferometry principle. It can image the meibomian gland. Also, it can image the lipid layer of TFM. So there are many instruments which can help us in imaging the meibomian glands. But the bottom line is we must image the meibomian glands. So once we find there is significant amount of MGD, then comes the treatment part. Well, the treatment part, again, in recent time, we have seen some very interesting devices which have come. One of such devices is something called LIPIFLOW. All these devices can be classified as meibomian gland expressor devices, or MGDX. Now, LipiFlow, or in the other market, international market, it can be something like iLux device. What it does is it gives the pulsation as well as it gives heat to the upper lid, with the safety that it does not damage the ocular surface, as well as does not damage the eye. And it gives the heat to the meibomian gland, and it gives pulsation. So it leaks out bad meibum out of the meibomian glands, and it works wonderfully well. Traditionally, we do repeat this thing after 3 to 6 months time, but even there are studies where it shows that even one treatment itself can significantly improve the symptoms as well as sign of the patient. Even if you do not have this thing, you can always do manual expression of meibomian glands using simple epilation forceps or any other forceps kind of devices, which can squeeze out the bad meibum and can help you to take care of these patients. There are other devices which are there in the market. They are called IPL, or Intense Pulse Light Therapy. Now, what they do is they give a significant amount of high power light around the lid, and which can help us to reduce the inflammation by creating antioxidant nascent oxygen molecules. Though the long-term outcomes do not tell us that these devices alone, standalone, can have significant role, but they combine with meibomian gland expression can certainly have a good role. Intense pulse light therapy per se can be useful in limited number of cases. So this was about the diagnostic part. Now, when we come to the treatment part, the treatment strategies hover around three things. One, we should supplement the TFM, which we normally do. And in fact, that's the only thing we do in the treatment of dry eye. We keep on pouring lubricant. But there are other strategies also which we can include. One is increase tear secretion by using certain chemicals or certain molecules, which we'll discuss. And other thing is to preserve the tear film by, again, certain maneuvers or devices. We'll go one by one. So coming to the lubricant part, now a lot of time we discuss that which is the ideal lubricant, which lubricant we talk about. In fact, our entire ophthalmology, we just end up talking about lubricants, and that's just one part of dry eye, because Unless you treat the root cause, your dry eye is not going to get treated. So we assume that we have treated the root cause, and then we come to these guys, or lubricants, what we like. We call them artificial tear or tear substitute. Well, that's misnomer, because there's no ideal lubricant. There's no tear substitute. If you look at the ideal lubricant, which should be preservative free, which should have all the electrolytes, it should have proteins, it should have all the osmolar protecting agents. It should have long retention time. It should have flexibility in osmolarity, and it should be biologically active. Well, of course, none exist, and none can exist, because it's a body part and which is an active fluid. But when we talk about lubricant, when we analyze lubricant, we analyze based on certain headings. One of them is preservative, second is electrolyte, third is viscoelastic agent, and fourth is osmolarity. We spoke about osmolarity part, but we'll look at the other parts one by one. So different eye, they like different lubricants. So that's very important thing to remember, that what you like, what your ocular surface likes, your patient's ocular surface may not like it. So please remember that. So first, starting with the preservative, this is the villain which we love to hate. Of course, we do not like preservative in our any eye drops. But if you look at the classification of the preservative, the worst is benzalkonium chloride or BAC. These are detergent type. The newer preservatives, what we have in lubricant, these are oxidizing preservatives like stabilized oxychlorocompound or purite or sodium perborate, where they turn into a relatively safer compound when they are exposed to either light, like stabilized oxychlorocompound, or sodium perborate when they are exposed to ocular surface. So though they are preservatives, but they may turn into less dangerous substance when they are exposed to certain environment. The benzalkonium chloride is, again, it's the epitome of or villains, like Joker, what we would say. We love to hate this guy. It's significantly epitheliotoxic, but when we use a drop 4 to 6 times a day, it's not as bad. Because if you look at the dilution factor, within 30 seconds, it's get diluted 8 times. And within 3 minutes, it's get diluted 36-fold. I mean, it's hardly there, right? However, if the surface is already damaged, or there are multiple medications which we are adding, or we do not have tear film turnover with either punctum occlusion or anything, it can have damage on the surface. So I certainly wish that we do have better preservatives, like these Venetian preservatives, but they themselves are not preservative free, right? So only preservative free are those unims, or now we have those special bottles, those Novelia kind of bottles, or the ointment form, they are preservative free. But we certainly wish that we do not want to have preservative in our lubricants. But if the surface is not compromised, they're okay. Coming to the electrolytes, that's another thing which we should look at when we look at the lubricant. The electrolytes, one of the important electrolyte which decides the osmolarity is sodium. The other is potassium, which is very important for the cell maintenance, especially the goblet cells and glycogen. The bicarbonate is very important for the cell growth and to maintain the cells. Unfortunately, that's an unstable compound. So if you are using a bottle which is multi-dose vial, and if they have bicarbonate, which turns into carbon dioxide, and once you open the bottle, well, that's a disappear. So though your drop may have your bicarbonate, it may not help. So every time, everything in the drop does not help. Even something like sodium, when we talk about sodium, that yes, sodium must be there to maintain the osmolarity. But do you know that when you combine sodium ion with certain lubricants like carbomer, it actually reduces the viscosity of the molecule. So if you just add things like sodium or any electrolytes in your lubricant, it's not necessary that it's always good for the outcome, right? So addition of isotonic saline in a carbomer reduces the viscosity. Now coming to the viscoelastic agent, and interestingly, whenever we talk about lubricant, we just talk about things. As you saw, that there are so many things in a lubricant also, and all we talk about, oh, I've given carboxymethyl cellulose, I have given HPMC. Well, that's just one viscoelastic agent. And what's the importance of that? Well, it increases surface retention time. Higher the molecular weight, longer the molecule stays on the surface. Low molecular weight, though, they may not stay longer on the surface, but some they may be more comfortable. So somebody who is less symptomatic, well, they are more comfortable with such kind of thing. So not always everybody feels more viscous drops are comfortable. Somebody with good TFM turnover can actually be quite happy with 0.5% CMC also. You don't need to give them 1% CMC every time, right? So coming to the viscoelastic agent, there are different classification that, and currently our favorite is cellulose derivatives like CMC, HPMC, and those things. But unfortunately, in our country, they have come into price control. So though all the companies wanted them, now suddenly they realize they can't charge more. So they now again have come back to polyols and polyvinyl alcohols like PVAs and those kind of things. So suddenly you see your CMC drops are much cheaper, but other drops like your polyols or polyol alcohols, they are more expensive. It's not that they are better. It's because they are not under price control and companies can earn more money from that. So that's why they're going to use them. So please be aware. Now, very interesting, polyols, like all polyethylene glycol, polyethylene glycol, they do not have significant viscosity unless combined with HP-GOR. So if you do not combine them with HP-GOR, they do not have significant viscosity. These are viscoelastic agent. Their job is to keep the drop on the surface for longer time, or something called ocular surface resident time. Now, the ocular surface resident time is not just function of that particular molecule or viscoelastic agent. There are many things which are responsible for ocular surface resident time. Something, the rheological property of your molecule, which is viscosity, your blink rate, the temperature of ocular surface, the pH of your molecule, TFM clearance, the adsorption of lubricant ocular surface, and evaporation rate. So all these things will decide how long a drop will stay on the ocular surface. Now, if you look at the studies which were done long back in 1992, one of the scientists, Dr. Anthony Braun from UK, I mean, he has done a lot of remarkable work on dry eye and ocular surface. Their group studied using quite good models using fluorophotometry and dye clearance and many scintigraphy and many things, and they found that the half-life, again, remember, the complete life of a molecule is not possible to detect because in fag end, they may not be detectable. So always we talk about half-life of a molecule, whether it's ocular surface or in body. So half-life of very viscous molecules like sodium hyaluronate, 0.2%, right, is somewhere around 5.5 minutes. And maybe full life, if we can consider double of that, is 11 minutes, which is never like that. So you think about it. Things like HPMC, their half-life is 44 seconds. So if you put such kind of drops 4 times in a day on ocular surface, they do not do anything. They are just psychological for doctors as well as for the patient, right? So please remember, the ocular surface resident time of most of these lubricant is very less. So irrespective whatever viscoelastic agent you use, you must use them more frequently at least 6 times or 2 hourly, 3 hourly, depending upon how the requirement is. The another thing which decides about the viscosity is the temperature of the surface. There are certain these viscoelastic molecules, when the temperature increases, the viscosity goes down. And some molecules like carmelos or hypermelos, they do not have significant viscosity in normal temperature of 32 degrees Celsius, which is, well, most of the part in India would be hotter than that. And they do not have significant viscosity. Even the things like our carboxymethyl cellulose and all those things, if you look at the ambient temperature, when it reaches 40s and those things, they are no more viscous. So simple thing, whenever we prescribe such kind of thing to the patient, we can just ask them to refrigerate it so that they can have better viscosity and better ocular surface resident time. So in Asia and our country, we must ask them to refrigerate. Another thing, which is pH of the molecule. Now, pH of the molecule also decides the viscosity. Certain things like HPGUR, like Cysteine Ultra, again, I don't want to take the name of the molecule, but you would connect to it more easily. If they combine with acidic pH, well, it turns into more water. It does not, it's not the HPGUR is liquid when it's acidic pH. So when you combine with medicines like cyclopentolate or tropicamide or aminoglycoside, well, it's not a good combination. So you do not want to combine your Cysteine Ultra kind of drops with such kind of things, right? So coming to the next part, which is preserving the tears, and for that we have Lacrimal Plugs. These are very small things, but not all small things they go without notice. They do make a lot of difference. And one of the classification is based on the duration. The short-term plugs are these collagen plugs, and which may last for a week time, which helps you to know whether it's going to work or not. Then you can have extended duration temporary plug, which can last for almost a few months time, 2 to 3 months time even, and which can actually give you a significant amount of idea about how they are going to work. And then there can be permanent plugs. So how do we use them? Well, are they useful? Certainly, we know from the literature, whether it's symptomatic improvement, Schirmer score, or TFM stability, they are better than just using lubricants alone. How do I use it in my practice? Well, if patient selection wise, if I find that this patient can have improvement with the punctum plug, I do a sac syringing. If it's blocked, not a good case. If it's patent, I use a temporary plug. And if there is any epiphora, well, may not be the best patient for punctum plug. But if patient can tolerate it, I can use either extended plug. And if they again end up with complication, I don't use anymore. But if they feel nice with that, either I can repeat that or I can do a permanent plug. Or if I have a case with a significant amount of dry eye and my Schirmer's values are very low, I can actually close the punctum by doing a punctum cautery. So this way, you can actually preserve the tear film also. So one, we saw that we could preserve the tear film using punctum plug. Second, we supplement the tear film, which we normally do. And the third thing is we can increase the secretion of tear film by using secretagogues. There are certain secretagogues which may not be available in our markets, like dicafosol, which shortly would be there in the market, which is available in Japanese market. They are mucin secretagogues, so they can help us in cases where there's mucin deficiency, and they can certainly improve your tear film breakup time as well as the symptomatic. Another secretagogue is Rebamipide. Rebamipide is anti-inflammatory as well as it's a mucin secretagogue. Mucosta or Rebamipide is actually used widely by our gastroenterologist for the gastric ulcers. and they certainly do very well. In the drop formulation, however, they have some anti-inflammatory action, but it may not show a significant change in your either fluorescent staining or your Shermer's value, but it certainly can be of help. The another molecules which is available, which we do not use, is pilocarpine. Pilocarpine is available as a tablet form from Sun Pharma. I do not have financial disclosure there, and it's available as 5 mg orally, and you can give 3 to 4 times a day. The disadvantage, they can have more salivation, they can have more sweating, and they can have more tears also, but in this sequence, more of saliva, sweating, and then tears. So somebody with Sjogren's syndrome, those with significant dry mouth and dry eye, this is certainly something which works very well. There are some biological tear substitute also which we can use, like autologous serum in various concentration, 20% to 100%. People have also used self-prick blood, which can be directly instilled, but autologous serum is a little more refined way of doing that. It can help us in cases of significant Sjogren's syndrome and ocular surface damage. But please remember, you need to maintain the cold chain, and otherwise this is a culture media where the infection can grow. Salivary gland autotransplantation can also be considered, but with the limited outcome of that. Amniotic membrane extract has been studied in West, though it's not available in our market, but that can help us biologically in tear surface, in the ocular surface when it's not stable, where there is persistent defect or erosions, where it can be of help. So when we go to the summarizing part, the diagnostic part, the mandatory tests are fluorescent staining and TFM breakup time, Rose-Wengal staining or Lessman green, along with the Shermer's test. These are the mandatory tests. Along with that, meibography is also a mandatory test. The meibography can be done using your autorefractometer or meibographer or some other diagnostic devices. The other non-mandatory test for dry eye can be your MMP9 or the inflammatory eye, or it can be non-invasive TFM breakup time, your lipid layer analysis, or the abrometry. Finally, whenever we are looking at the treatment, we also decide the treatment based on the severity or the severity of the disease. And based on that, you can have treatment in different steps. The step one, well, you can, it's a mild treatment dry eye, so you can just educate them, modify the environment and all those things. Step two, well, it's a little more dry. You can use punctum plugs and tear conservation. Your MGD treatment and in-office treatment can be done. Step three, which is more severe ocular surface problem, where you can add along with your lubricant secretagogues as well as your autologous serum. And very bad ocular surface, step four, well, amniotic membrane transplant can be considered, as well as permanent closure of the ocular punctum can be considered. To conclude, change in understanding of dry eye has led to discovery of many different diagnostic devices and instruments. To treat a disease like dry eye, you must know the pathophysiology, and especially in an individual patient, you must come to a diagnosis based on your pathophysiology. Newer instrument devices like LIPIFLOW, meibography can help us diagnose the evaporative dry eye, and the modalities like immunomodulators and secretagogue are going to be helpful in future also. Thank you very much.
Thank you so much,
If there
sir,
are any
for
questions, I'll
covering
be happy
such
to
an.
take.
Sir, am I audible, sir?
Absolutely, you're audible.
Yeah. So thank you so much for covering such an important topic. I mean, this topic is important not only with from the post graduation point of view, but also for an ophthalmologist for throughout life. This is important. And I must say
Of
that
course.
the postgraduates should actually take a look at those flowcharts and the regimens that you've put up, because if they draw that in the paper, it's definite and sure shot that they'll score really high. The amazing flowcharts that you've put up.
Thank you, Rolika.
So would you like me to take up the question, sir?
Of course, yes. Of course, yes, please.
So one of the viewers would like you to explain a little bit more about the osmoprotective agents.
Okay, so basically, osmoprotecting agents are these solutes. So remember, the solutes are responsible for. There are two different types of solutes which we normally deal with. Those ions, different ions like sodium, potassium, they are also solutes, but they decide the osmolarity. And then there are certain other solutes, they are non-soluble molecules. These things, they help you to prevent the damage of osmolarity. Now, osmolarity damage, how does it occur? Whenever a cell is exposed to hyperosmolarity, the sodium ion is going to pull out the water from the cells. And then it's going to get replaced by taking more water inside by the cell through its semi-permeable membrane. This would be uncontrolled, and at one point of time, the cell would swell and it will burst. And that's how an osmotic damage occurs to a cell. So what osmoprotecting agents do is, like, as I told you, there are different osmoprotecting agents. Some agents like glycerol, which are very small molecule, which can enter into cell very rapidly. So it prevents any hyperosmotic state inside the cell, and which does not allow the cell to swell up significantly. Now, the glycerol molecule is small, it leaks out also fast. So if you just keep glycerol in the lubricant, well, it's not going to give you protection for longer time. So then there are some other agents which can actually give you little longer duration of protection, like L-carnitine, which is a molecule which is osmoprotectant, which goes easily in the cell, but for it to come out, it has to come out with an active transport along with the sodium ion. So in such condition, it's not going to leak out very easily. So even urea, these are all osmoprotecting agents. So they, based on their molecular weight as well as based on how they are transported, you can have different duration for which your cell can sustain an osmotic insult by anything, right? So there are all these osmoprotecting agents which are part of your lubricant. Many of your lubricants, they have them, and hence whenever you use these kind of lubricant, whether it's an hyperosmolar or hypoosmolar surface, it helps your cell to sustain the osmotic damage.
Right, sir. So how is LipiFlow used in terms of duration and procedure? What's the exact procedure, sir?
Yeah, so basically LipiFlow, what it does is it's thermal pulsation device with active Mebon expression. So simple thing, what we tell patient for MGD, warm compresses and lid massage, right? Now lid massage is done vertically because the Meibomian glands are vertically oriented. So you do vertical lid massage. And why do we do warm compresses? Well, it's like when you guys go to, or when anybody goes to a parlor for facial. So first they give steam. Why do they give steam first? Because the Meibomian secretion or the sweat secretion or the oil, whichever has come out, when it gets denatured, it gets solidified. These are polar lipids and it gets solidified like wax kind of thing. But when you give them heat, they actually melt. So when you give steam or anything with, actually it melts all those bad lipids, and then they do massage on the surface. So same way with the warm compresses, you are melting those bad lipids, and then with the massage you express them out. So what LipiFlow does is LipiFlow does both of them together. It it delivers an optimal temperature on the lid margin, on the lid in fact, where there is a protection inside the eye so it does not damage the ocular surface or cornea. And then it has pulsation also, which expresses the meibomin secretion, so that you actually effectively treat that particular thing. So that's how it works.
Okay, so how to differentiate between RB stain in dry eyes or ocular surface malignancies?
Okay, so I don't think it's as confusing as we think. Ocular surface malignancy is the diagnostic feature is not staining alone, right? It's just one of the feature, right? So we know that there are a lot of other features, how the color of the lesion is there, what is the consistency of the lesion, are there those internal vascularity there, are they feeder vessels there, and on top of that, if we have staining, then we may connect that to the ocular surface squamous neoplasia. But randomly on an ocular surface, if there is a staining, of course, that's not related to ocular surface squamous neoplasia. Also,
So
in dry eye, the
ideally,
staining follows the pattern. So dry eye is it related to something related to exposure. So your staining would be more in the palpebral fissure area, which is exposed. So if you lift the lid, but if the significant amount of damage is there or surface is really dry, even when you pull the lid, there can be staining there also.
right, sir. So for a meibomin gland disease patient, like what is the actual, what do you recommend? So warm compresses and lid massage, and along with the topical and antibiotics. So what do you recommend, sir? Like what is
So
your regimen for the same?
yeah, so so depending upon the severity of the disease, remember one thing, that whatever drops you use as an antibiotic does not reach this place. So whether it's an anterior lid margin or posterior lid margin, antibiotic drops do not have any role. They do not reach there. So if you want to deliver antibiotic there, either it has to be in an ointment form, which you apply at the lid margin, or it has to be systemic. Now, there are certain conditions where the large part of this thing gets colonized by bacteria, like if you see rosacea. Now, rosacea cases can have significant amount of bacterial colonization. Memomitis associated keratoconjunctivitis or MRKC, memomitis related keratoconjunctivitis, can have significant amount of bacteria which can grow in the meibomin glands as well as the lid margin. Now there you have to give them systemic antibiotics. So a very significant amount of MGD and chronic disease along with the skin issue, I would certainly give a systemic course of antibiotic. I prefer doxycycline being safer and easy to use. I use, again, the regimen can be different. I use twice a day for 15 days and once a day for 15 days. And topically, I like to give warm compresses, lid massage, lid cleaning with whatever solution you use for this cleaning solution. And then an antibiotic ointment at the locally at the lid margin, like optithromycin or azithromycin any Ocupol kind of devices, antibiotic. Basically, you want to take care of gram-positive organisms there.
Okay, so one of the hot seat participants have asked that should we use topical anesthetic before fluorescent staining, and even should we use antibiotic eye drops before that?
That's a very good question. Now, for the fluorescent staining, you do not need a topical anesthetic agent for sure. Ideally speaking, you should dilute it with a balanced salt solution, BSS, in a small micro droplet form. Ideally, there should be solution of your fluorescent available, and they take a device like, say, so if you look at, if you want to know the real science behind it, well, in Japan they standardize all such kind of methods. How do you do ocular surface staining? So in Japan, the standard staining method is you use liquid fluorescent. So what we use sodium fluorescent for our FFA and all those kind of thing. They take device something like toothpick, dip that into that, and touch that on the lower palpebral conjunctiva. So only that much amount of fluorescent which you to use. Well, it's not very practical here. So we use strips. We use again. Can we use the antibiotic? Certainly not a great idea. But ideally, you should be using a BSS, which we may not have it practically available. So we use preservative-free antibiotic, small drop, remove the excess amount of fluorescent, and then just touch the tip of that thing on the lower palpebral conjunctiva. Just tip of that. Do not smear it on the surface. That's the ideal method.
Okay, sir. So what is the lubricant regimen that a contact lens wearer should follow, and even for a computer vision syndrome?
Okay, I don't think there is any special thing which you can follow, anything like that. But remember, contact lens can sometimes, if not always, can work adversely with certain lubricants, because they stay there stuck. They get stuck to the contact lens, and it may not be the most pleasured thing for them, having a coated contact lens and unfortunately blurry vision. But a low viscous lubricants like 0.5% CMC can be fine. The second question you said with computer vision. Okay, again, well, it's not just, again, we simplify, as I told you, we simplify dry eye based on just lubricant. We talk about lubricant. Which lubricant can I use? Well, for computer vision syndrome, you can work on the rest of the things, that patient's blink rate, the position of the monitor, whether the palpebral fissure width is too high, patient has lower lid retraction, patient has nocturnal leg of thalmus. You can ask the computer professional to keep the monitor a little below, AC should be away, blink more often, take more breaks, and use lubricants which does not blur your vision, which you feel comfortable on your surface, and whichever you feel nice about. So that's okay.
Okay, so the last question that I'll take up is that in glaucoma patients, do you recommend addition of topical lubricants prophylactically as the topical anti-glaucoma medications are started, or after a few weeks of the treatment, because they're going to be long-term usage there? So
that's a very good question. And certainly glaucoma medications can be significantly surface toxic. Having said that, does it mean everybody who is on anti-glaucoma medication leads to ocular surface damage? Not exactly. Does it mean that whenever there is ocular surface damage, if you add lubricant, that damage will be cured in spite of using those anti-glaucoma medication? Not always. Many times we have to request the glaucoma specialist to change over the treatment regime, or give them something which is without preservatives, or sometimes even stop them for a while to take care of the ocular surface. So having said that, when we have glaucoma medication going on, and if you find that there is some surface staining, you always can combine with the lubricant drop, and there's no harm in that. But we have to remember, the priority is glaucoma treatment and not the lubricant.
Definitely, sir. Thank you so much, sir, for covering all our questions and for the wonderful presentation. I definitely love the flowcharts. I'm like, they should totally use it in their papers.
Sure.
Thank you so much, Himanshu. Thank you so much.
Thank you, Dr. Santosh. Thank you.
Wonderful lecture.
Thank you. Wish you all the best for your exams in life. Thank you.